So thank you everyone for joining us this afternoon for our webinar. This webinar has been organised by the Safer Healthcare Biosafety Network and Patient Safety Learning as part of the Safety for All campaign. The Safety for All campaign was set up 2 years ago and it's an awareness raising campaign which draws the similarities between healthcare worker safety and patient safety, spotlighting various healthcare worker issues and patient safety issues across the UK. If there's an issue with my sound, I apologise. Let me try and fix that. Just quickly answering a question. The webinar is being recorded and will be accessible online following this. We'll send everyone a link. The webinar today is called Why We Need to Talk More About Sepsis, and it is in partnership with the UK Sepsis Trust. The UK Sepsis Trust was founded in 2012 by NHS consultant Dr. Ron Daniels, who is joining us today. 5 people die with sepsis every hour in the UK. Sepsis is a serious complication of an infection. Without quick treatment, it can lead to multiple organ failure and death. Sepsis often goes undiagnosed, and it is important to raise awareness of the symptoms and what to look out for in order to reduce the number of sepsis-related deaths in the UK. Today, to talk about sepsis, I would love to welcome Dr. Ron Daniels, founder and joint CEO of the UK Sepsis Trust, and Melissa Mead, who is here to share her personal story and experience of sepsis and is also a passionate campaigner around the issue. Before I hand over to Ron, I would just like to say that if anyone has any questions, please pop them in the chat, and we will either we'll answer them at the end of Ron and Melissa's talks, and also perhaps on the fly if any questions come up, but I'll be keeping an eye on. So Ron, I'd like to hand over to you. Thank you.
Thanks so much, Josh, and good afternoon, just everybody. My name's Ron. I'm an intensive care clinician. I have just finished my morning shift, so it is safe that I'm talking to you now, but apologies for my attire. Apologies also if my signal goes a bit off, because as those of you who have worked in NHS acute hospitals will know, I'm not allowed to access the Wi-Fi, so I'm on my personal hotspot, but we'll give it a go. So I'm going to try to share my slides. Can you now see something quite colourful?
Yes, that's working well. Thanks.
Perfect. So what I want to talk about is sepsis across the healthcare system. And that means from contracting sepsis or developing sepsis, in which 80% of cases arises in the patient's home, through to recovery. So we're going to try and encapsulate the whole thing in 20 short minutes. A reminder of what sepsis is. It's a life-threatening condition arising when the body's response to infection causes organ damage. Now, obviously, this is the lay definition. It's an official definition, actually. It was coined in 2010. It's called the Marinoff definition. The health professional one is very similar, but naturally uses more inaccessible language. So we describe it as a dysregulated host response to infection. And really what that means is that sepsis is not a severe infection. Sepsis is the immune system and other body systems going into overdrive and misreacting to the infection. And it's that, the immune system, that causes the organ damage. Now, this is Villa Park, the home of Aston Villa, who are one of my local teams. At capacity, Villa Park holds around 43,000 people, and it gives us some interesting context. And I use Villa Park because the young man whose death started me on this journey, Jem Abbott's, he was a season ticket holder at Aston Villa. So this is a very poignant slide for me. Breast cancer claims around 11,000 lives in the UK each year. Bowel cancer rather more, around 16,000 lives lost. And of course, it's right and proper that we continue to strive to improve outcomes from those conditions. Sepsis is estimated to claim 48,000 lives every year across the UK, which is more lives than are claimed by breast cancer and bowel cancer and prostate cancer put together. But of course, these conditions can coexist. An obvious example being someone on chemotherapy for breast cancer developing neutropenic sepsis. But the basics of sepsis care and some aspects of intensive care medicine remain appropriate even for people being palliated for one of these underlying conditions. So we think it's quite reasonable that we double count. Sepsis is not a condition that only affects very old and very young people. We often hear that it's primarily a condition of the elderly. Now, it is true that you're more likely to develop sepsis as you age, but that's not the same thing as saying that it only affects old people. New York State has the world's best funded and best legislated sepsis improvement initiative across a population of just over 20 million people. And they produced data quite recently for the year 2019, and they showed that almost half of adults admitted to New York's hospitals in 2019 were of working age. Similarly, among children, we often hear that sepsis mostly affects very young, very frail, premature neonates and children with lots of comorbidities. And you're going to hear quite shortly and very impactfully that that's not true. But the data from New York State bear this out as well. In New York State in 2019, slightly over half of children admitted to hospitals with sepsis were of school age. So yes, it's true that you're more likely to get sepsis if you're very young or very old. You're more likely to die of it if you're very young or very old, but it can clearly affect people of any age. Now, I need to talk about severe infection as well, which is we might define as infection requiring hospital admission and intravenous antibiotics. And in high-income countries like ours, these four sources of infection at the top there give rise to 95% of cases of sepsis. Pneumonia is the most common source of sepsis in adults as well as children. It's not meningitis in children, it's pneumonia. Urinary tract and intra-abdominal infection, depending on which study you look at, vie for between second and third place. But broadly, they account for about 15 or 20% of cases each. And then skin and soft tissue, bone and joint infections, which is things like cellulitis and septic arthritis, they account for around 10% of cases. And these are important. We decided to look at how many admissions to English hospitals we saw during a given year, and we accessed the data through NHS England for 2017. And we chose the obvious diagnostic codes pertaining to those four sources of infection, the pneumonias, the cellulitis, the peritonitis, the UTIs. And we did a head count. And it was quite a staggering number. 1.7 million hospital admissions in England were either caused by or complicated by infections in those sources. Now, this is from coded data. It's not perfect. There might be some rubbish data in there, but it's still a big, big number. Why am I telling you this? Well, really for two reasons. These are the sources of infection for people in whom we need to actively look for sepsis. So if we admit someone to a hospital or we see someone in the community with a pneumonia or UTI or an intra-abdominal problem, we need to be on the alert for sepsis. The second reason it's important is from the perspective of antimicrobial resistance, which is a very real and current threat. Now, I'm at quite a small hospital today. We've only got 6 patients on our intensive care. I'm not going to break any confidence, but 2 of them have multi-drug resistant bugs, and that's a pretty normal situation. AMR is here today. It's influenced by our desire to prevent people dying from infection. It's not influenced by prioritizing sepsis or by anything else. It's a natural consequence of our desire to stop these 1.7 million people dying from infection. And we need to sort of grow up a little with our messaging around AMR. It's here today, it's affecting people personally today, and it is a natural consequence of bacterial evolution. What we have to do is to address it without beating people up for prescribing antimicrobials. Obviously, we need judicious antimicrobial prescription, but we shouldn't do head counts of antimicrobial prescribing without clinical qualification. The data I shared, the 48,000 deaths every year from sepsis, come from this study, which hit our shores just before the pandemic, and it's from the Institute for Health Metrics Evaluation in North America. These are the people who write the Global Burden of Disease report for the WHO. So although these are estimates, they're very credible estimates. And they gave us country-specific data showing that the UK is estimated to have 245,000 episodes of sepsis every year, with 48,000 people dying. But look at those global figures. 11 million deaths among 49 million people developing sepsis every year, with quite staggeringly almost half of those deaths in children under 5 in resource-poor countries. Now, Obviously, I'm an intensive care clinician. I know how horrible COVID-19 was. I know how horrible COVID-19 will continue to be for a small number of patients each year over the next probably decade. But at its peak, it was a very horrible experience for me and my staff, as well as for the people affected. Johns Hopkins University stopped counting deaths from sepsis in February 2023, but in the 3 years leading up to that period, they estimated 6.8 million lives directly lost as a consequence of COVID-19. I'm not diminishing how horrid COVID was, but sepsis claims 11 million lives every year, nearly double what COVID claimed in 3 years. And that's why governments around the world have started taking this really seriously. We've taken this messaging to the G7 summit through my other role as Vice President of the Global Sepsis Alliance. We've taken it to G20. We recently presented around sepsis at COP28. And it really started when we got a resolution on sepsis adopted by the World Health Organization in 2017. And when we did so, we wrote an opinion piece in one of the journals, and we asked the former Chief Medical Officer, Sir Liam Donaldson, to write a foreword. And he said some very important clinical issues, some of them a matter of life and death, exist in this backwater inhabited by academics, professionals and enthusiasts. But Sir Liam went on to say that the public and political space is where sepsis needs to be in order for things to change. So I'm now going to describe 3 key activities of our charity, and we're going to start with public awareness, segued by Sir Liam. We don't pay for any of this stuff, and actually a lot of this stuff is Melissa's job because she works with us in the charity now. The messaging on big noisy yellow vans is not paid for. It's free. It's now on 9 of the 10 English ambulance services with variable penetrations of their fleet. It's really important. Ambulances, we're going to have to livery this space anyway, so it doesn't cost them anything to livery with our messaging. All it cost us was design work and the relationship that we formed with the then Secretary of State, Jeremy Hunt. And the messaging within it, those symptoms that spell the word sepsis, was drawn from very extensive consultation with Public Health England and the Royal Colleges. They weren't plucked out of thin air. Similarly, we don't pay for large format advertising space in city centres. It's donated to us when space is unsold. We work with large organisations. This is a different football club, and they just put some messaging on their website. So the message to them is use existing dissemination mechanisms. You don't need to pay thousands of pounds to do this. Just do some design work and get the message out in the best way you can. We work with television. This was Holby City, but we've worked with Coronation Street, EastEnders, Call the Midwife, Hollyoaks and others to get the message out there responsibly to our public. And then we're starting to educate school children through this programme, Schools Against Sepsis. This is funded by Iceland Foods, the frozen food retailer, and we've got messaging available for key stage students across all key stages that is approved under the PHSE curriculum. So we've now got, I think, around 2,000 schools signed up last time I checked. It might be more now. The second thing the charity does is help people affected sepsis. And really that's 3 categories of people: people who've survived, people who've been bereaved by it, and carers of survivors, the often forgotten group. So we have support nurses that are available during extended office hours. They provide telephonic support, email support, peer-to-peer support groups. And as you would expect, we've got lots of printed material to help people to understand what's happened to them and why it's taken them a long time to recover. The after effects of sepsis are very similar to long COVID. You've heard of brain fog. Well, look at this study. When was this from? 2010, I think. Yeah, 2010. So, long before anyone had thought of COVID-19 and brain fog, cognitive dysfunction after critical illness with sepsis is well described in the literature. 17% of people who survived sepsis in this study had moderate to severe cognitive dysfunction. Now, what does that mean? That means that we deal every day with people who are struggling to return to work, struggling to care for dependents, can't return to work at their previous level of function. So this can break people. PTSD, the psychological domain, we see in 22% of people who've had sepsis bad enough to require intensive care unit stay. And, look at this against other things. That's in the ballpark of people who've been on the battlefield. So it's a very, very significant psychological experience, particularly if your sepsis is bad enough to require intensive care. And in the physical domain, sorry, that's the next slide. We know from an international survey we did that about 40% of survivors of sepsis suffer long-lasting effects. These persist at 1 year after their illness in one of these three domains: physical, cognitive, or psychological. And the physical can be really obvious. It can be limb loss, it can be digit loss, but equally disabling are the invisible physical sequelae, which is a bit of a mouthful. But disabling fatigue syndromes are one of the most common things reported. People simply cannot function at their previous level of function from a physical perspective. This was an interesting, albeit small, Scandinavian study. They followed people up who were in full-time employment before they got sepsis between the ages of 18 and 57. They chose a sort of slightly arbitrary cutoff at 57 because they wanted to exclude people who might naturally retire. And they followed them up for a year, and they found that 57% were back at work at 1 year, 43% were not. That's almost half of people were unable to return to work for a year. Now, that might be fine for those of us in the NHS. We're probably going to be supported, but we will be compromised on our income after a few months. And if we were self-employed, critical illness cover is unlikely to cover this. So it's really important that we raise the profile of people affected by sepsis. And at the moment, the best we can offer is support from our support nurses, which is brilliant and very well received, but they should surely be centrally resourced. Now, the third thing that we're known for is the clinical space. And I'm going to finish by talking about the clinical space over the next 10 minutes or so. There's been huge change, and when we talk about stuff that's hot off the press, as will soon become apparent, we really do mean hot off the press. Now, we have to screen patients for sepsis. What do we mean by screening in this context? We mean we take an undifferentiated population, probably qualify it with people who we think might have an infection or think might be ill, and we need to identify which ones we need to actively look for sepsis in. Now, there was a proposal in 2016 following a large academic piece of work around a large database that we use this tool, QuickSOFA or QSOFA. SOFA was the acronym for the official definition of sepsis, which really no one uses outside research. It's very, very complex. QuickSOFA was intended to provide us with a screening tool. And it was intended that we look for people who have 2 or more of these 3 QSOFA criteria. Now, when these were proposed, there was some anxiety in the UK because it used the same parameters as News 2, but with different thresholds. And we thought that that was going to cause confusion. But nonetheless, this was rooted in reasonable academic work. However, it was all retrospective. And when they tried to look at it prospectively and compared it with early warning scores and the old SIRS score, they found that other scores were better at QSOFA than predicting who was going to do well or badly. So since 2021, the International Academic Guidelines Group on Sepsis, the Surviving Sepsis Campaign, have strongly recommended against the use of QSOFA, recommending instead that we use News. And obviously, we're sitting quite pretty with this within the UK. So News 2 was launched as a follow-on from News in 2017, and we and NHS England, and as of yesterday, that's how hot off the press this is, NICE recommend that we use News 2 as a screening prompt for sepsis. Now, that doesn't mean replace clinical judgment, as our clinical tools demonstrate. Now, I'm going to share the clinical tool for general practice next. That hasn't changed much yesterday, but other tools have. I'll come on to those in a moment. So the screening tool for general practice, and obviously this is sort of promoted or displayed as a paper document. We're not naive enough to think that GPs have myriad paper documents to cover every condition within their surgeries, but it gives us a framework with which to assess the patient. So we have these tools for all facets of healthcare: community-based care, pre-hospital care, dental practice, general, everywhere pretty much. We have community care tools for palliative care areas as well. This is the adult tool for general practice, and we start the process with a patient who looks unwell or who has abnormal physiology. We don't say News in general practice because it's not uniformly used in general practice. So if the vital signs are abnormal, or if you as a GP are worried about the patient, you start the screening process. We then move on with is there clinical suspicion of infection? You know, is the patient coughing up green stuff? Does the patient have offensive smelling urine and so forth? We don't need a diagnosis of infection. We need a suspicion of infection. And then we look for a red flag. Now, these are physiological criteria as well as routinely assessed criteria that can help to guide us as to whether the patient is very, very sick or not. And we worked at the time with the Royal Colleges and NHS England to get these criteria right. So they might not be perfect, but they were agreed by a broad cross-section of clinical societies and colleges. Apologies for the formatting there. Melissa and I were working very hard this weekend updating 31 of these tools, and we're not designers, so we didn't have our designer available at the time, so we have some changes in font within this. But nonetheless, it describes the current state of the art with general practice in terms of who we should look for. So if there's a red flag, we start the GP bundle, which I'll describe in a moment. If there's an amber flag, which is a slightly softer set of criteria, then the GP needs to make a conscious decision. Is it safe to keep this patient in the community? If I am going to keep them in the community, then do I need to schedule a second assessment? Do I need to send some bloods and review with the bloods? And I should give specific safety netting advice. But if the decision is to send the patient to hospital, or if they've got a red flag, we start this GP bundle, which used to say something, really very simple, call 999. But we recognise, and NICE now recognise, that getting an ambulance to a GP surgery or a patient's home isn't quite as straightforward as it used to be. And so NICE, this language was in there in 2016, but I think it's really important now that GPs should consider putting in place mechanisms to be able to administer intravenous antibiotics to patients suspected to have sepsis. And I think that becomes really important, particularly in more remote areas or at busy times of the year. But yesterday's news, now that's usually meant to suggest that something's a bit old hat, but this is properly hot off the press. Yesterday, NICE updated their guideline. And if you're charged with dealing with patients in one of 3 clinical settings who are age 16 or older, then this affects you. Those 3 settings are ambulance services, which we call pre-hospital services, acute hospitals like this, and acute mental health facilities. If you're in one of those 3 clinical areas dealing with adults and older young people, if that makes sense, then this is for you. It started a couple of years ago. So NICE haven't conceived of this themselves, but there was professional disquiet around the need to give everybody with suspected sepsis antibiotics within 1 hour. And this academic group, who provides the most credible international academic guidelines, said we need to be pragmatic here. We've got reasonable evidence in people who are very sick with sepsis that we should give antibiotics within 1 hour, but in people who are a bit less sick, we don't have such good evidence. So they said we're going to give antibiotics within 1 hour if the patient's got shock, and we're going to allow a broader time window of 3 hours if they don't have shock, particularly if we're a bit unsure of the diagnosis. Our Academy of Medical Royal Colleges got involved in this country, and that's culminated in yesterday's update to the NICE guideline NG51. And it looks like this, that if you're in one of those 3 clinical areas and the patient's 16 years or older, we start the chart if we suspect sepsis. And there's various criteria there that reinforce in whom we should be thinking sepsis. We then call an FY2 or above to assess the patient. Now, we wanted to put in or equivalent, recognizing that there's many non-medical professionals who have extended roles, but NICE are being pretty rigid on this. I can't explain why. They're going to get some further information and then make a risk assessment. Either if the News 2 score is 7 or above, they're very sick, they're red flags, we're going to get on and treat within an hour. But if their News 2 score is lower, then they might be an amber flag. And there's several criteria that can bump the patient up a notch there, and you can read them for yourselves. I'm not going to go through them in the interest of time, but it is a simpler list than the old red flag criteria. So the take-home message here is there's now 2 thresholds of news in those 3 clinical areas. Is it 7 or above, or is it 5 or 6? But if the patient's got a lower News 2 score with one of those several criteria below them, then we can bump the patient up a notch. Red flag, we start with sepsis 6. Amber flag, we're going to take some bloods, make a sensible decision and give antibiotics if they're indicated within 3 hours. And the sepsis 6 has changed slightly, and I will finish in a moment. Step 1, inform a senior clinician. We don't need a senior clinician to attend. That's not always practical. Get them informed. Step 2, correct hypoxia. That hasn't changed. And step 3, send a full set of bloods, including blood cultures. The only thing that's changed there is rapid pathogen identification strategies. Step 4 is now give antibiotics and think source control. That hasn't changed since 2019, but it has changed only a few years ago. Step 5 is give intravenous fluids. There's subtle changes there to the way in which we guide intravenous fluid therapy, but they're not significant. And then the monitor bit hasn't changed. The most important word on all of these tools remains the one on the bottom left of your screen, variants. If someone writes in there, I think this is viral gastroenteritis, I'm going to wait for more information before I give antibiotics. Of course, that's sensible medicine. That's clinical judgment. We should not discourage that action. We shouldn't discourage people thinking. Again, apologies for the formatting, but if the patient is a child, then we're sticking with red flags. So this is the pre-hospital or ambulance service tool for children under 5. Uses very similar language and similar red flags, with the exception that, of course, children's physiology varies with age and with body weight. So we've got criteria for moderate or severe tachypnea or tachycardia at the bottom left there. Now, I know I'm out of time, so I'm going to fly through a couple of the slides, but I think there's something really important we need to put in place here. Now, first thing, it's not just the NHS. This survey was across 6 European countries, and they all said we've got too many patients and too few staff to deliver this properly. So we alert the media of that as part of our public awareness activities. Now, this is the important bit. This letter to the Lancet was by some disquieted health professionals who thought we were over-egging sepsis a bit. And they said, sepsis is mostly about old people. We've dispelled that myth, but it's resulted in a doubling of antibiotic use in emergency departments. Well, that was alarming, and this is important. It followed a national commissioning incentive across England, which was hugely successful. We went from a third of patients getting antibiotics within 1 hour in 2016 through to 80% in 2019, with some suggestion from and differing methodology studies that outcomes had improved. So the first study showed a mortality rate of 30%. The last study showed a mortality rate of 20%. It's interesting. It's not cause and effect, but it's probably at least in some way related. But back to these data around antibiotics, and this is the penultimate slide. Antibiotic use in EDs did double, not from 2016 when we started, but from 2014. But we'll give them the artistic license because antibiotic use doubling is a good headline. It didn't account for the fact that we were using EDs very differently in 2019. Patients were staying there a lot longer and likely to receive more than 1 dose of antibiotics. And these data are measured in doses of antibiotics. But the most important stat wasn't reported in the letter. It's over on the right. Total use of antibiotics in hospitals, including in EDs. It barely changed. Yes, 1% is worse than 0%, but it's certainly not a doubling. So I believe what these data actually show is that incentivizing better sepsis care resulted in us giving antibiotics earlier in the patient journey, probably saving lives, without the adverse consequence of increasing total consumption of antibiotics. Apologies for going over by a couple of minutes. Thank you very much for listening. Look forward to the discussion later.
Thank you very much, Ron, and no problem at all. Really interesting in-depth look at the numbers around sepsis. It's quite shocking, actually, the wide-ranging effect of sepsis in the UK, also globally. Interesting to hear about the activity of the UK Sepsis Trust, and I think there's small changes that we can all make to make impactful improvements. I know I'll be looking out and next time I watch Call the Midwife for a UK Sepsis Trust poster. Hearing about how your charity helps those affected by sepsis was informative, and the various ways you can impact patients through physical, cognitive and psychological effects of sepsis. Of course, raising the profile of people suffering from sepsis is a great call to action, which I hope everyone listening can take away. Similarly, the screening tools that we looked at are incredibly comprehensive and useful, using the flag system, the importance that GPs can administer antibiotics IV, looking at News 2 and the latest NICE guidance, it's clear your work is having a very positive effect. Of course, there's still more to be done. There's some very practical advice there, which I know that many people on this call will have found useful. So thank you for that. And I'd like to hand over to Melissa Mead for the second half of this webinar. And I'd just like to remind anyone, if you do have questions, please put them in the chat and we'll try and get to them at the end. So thank you, Ron and Melissa.
No worries. I was going to say, Ron, the couple of questions in there, I suspect Ron will probably answer because they're quite easy to answer by typing in there.
Yeah.
But yes, so hello. I am going to share my screen and I'm just going to add a caveat at the beginning because I'm going to talk about my story or about my son's story, and sadly he died. And so I'm not the only person in the world that has been affected by child loss, so I won't be offended if you need to leave the room or you know take 5 minutes to yourself, because it can be quite triggering. So I will just share my screen with you now, and hopefully you should be able to see my screen.
Yeah, that's all working.
Yeah. So so this is William, and he is my son. And this photo was taken when he was 10 months old. And he was known as what's an unremarkable baby. So I was pregnant, I went into hospital, I had the baby and I went home and there were no complications. And William was born a healthy baby. And we embarked on maternity leave like most people. And he didn't have any illnesses whatsoever. So he wasn't what I would call a sickly baby. The only thing that he was known as was the Gaviscon kid, because he just didn't like to keep his milk down, although that was starting to get better as he got older. And I went back to work in the September 2014 and William started nursery. And within a week or so of him starting nursery, he came home and he was full of cold, snot, rubbing his eyes, coughing, you know, just generally just full of germs, I think. And we kind of really expected that because he hadn't really mixed with other children. So, you know, kids lick each other and poke each other in places that they shouldn't and share their germs around. So we didn't really think too much of it. I suppose after a day or two, it looked as though he was struggling to swallow, and but being under one, I couldn't ask him if his throat was sore because he couldn't tell me, and I'm obviously not able to look in his throat. So I took him off to the doctors and they said to me, my goodness, that they were surprised that he wasn't actually more poorly, because he had really bad tonsillitis. So they started him on a course of antibiotics. The next day he came out in scarlet fever, but we were on the right antibiotics. So we kept him off for a week so that he could fully recover. But he wasn't really ill with it. He wasn't, I mean, obviously children of William's age, they compensate until they can't. And then the moment they can start playing again, they do. So they don't sort of take to their bed and feel like, woe is me. So he recovered and he was fine and he started back at nursery again. And so we're sort of in mid-October now. And after about a week, he started coughing. And it's now what I know to be called a self-limiting cough. So he would sort of and then get on with it. It didn't keep him up at night. It didn't stop him doing activities. It didn't stop him eating. He was well in himself. He just had a bit of a cough. And I said to Paul, William's dad, after about a week, I said, have you noticed that William's got a cough? And he said, well, I have actually. So I said, I might leave it a couple of days and then take him in. And so I live in Cornwall. And at the time, we were, I suppose most people would call it blessed to see the same GP, the same family doctor. Unfortunately, that was a bit of our downfall. But so after a few days, we took him into the doctor and he looked in his throat, listened to his chest, looked in his ears. Everything's clear. He's just got a cough. He started nursery. It's a virus. You know, you are a first-time mum. You're bound to be worried. And I sort of expected to be told that, to be honest. I didn't anticipate him to be really unwell because he wasn't unwell in himself. So I went home again and we go on another couple of weeks and I noticed that he's coughing more often, so more frequently and for longer periods of time. And I started noticing that he'd cough in the night as well. So I said to Paul, I think I'm going to take him in again. You know, we've sort of been going 3 or 4 weeks now and his cough is sort of getting worse. It wasn't really bad, but it was just niggling away in the background and it was sort of getting worse. So I took him in and we saw the same doctor, and he listened to his chest, which was clear, ears are clear, throat's clear, he's happy in himself. You know, you're bound to be a little bit worried or anxious, you're a first-time mum. And I sort of heard that quite a few times, that you're a first-time mum. I'm a second-time mum now and I'm still worried, so it doesn't really matter whether you're first or second. So but he said this was just a viral infection, and, you know, sort of to anticipate that the next few years are going to be a bit like this with school and things. So I took him home again and we celebrated his first birthday, which happens to be my birthday. He was born on my birthday. And it was at this pub or restaurant that I said to Paul that he looked like he'd lost a bit of weight and he was pulling himself up and walking around furniture. He was sort of really quite mobile now, and he'd just taken his first steps. And I kind of thought, well, maybe it's because he's active that he's lost a bit of weight. And the next day we took him home. Well, the next day when we were at home, he had his breakfast and he coughed so much that he was sick. And it wasn't a tummy bug sick. We all know what tummy bug sick is like. It was literally, he just coughed and brought his toast up that he'd eaten. And I said to Paul, it's just not right. Something's not right. He shouldn't be doing that. And so I decided to take him to the doctors again. And I asked to see a different doctor this time. And I don't necessarily think there was a conscious decision that I thought that there was something wrong with the previous doctor. I just thought perhaps it's subconsciously that a new pair of eyes on him would, I don't know, just be different. And I can remember walking into this doctor, and before I'd even sat down, she looked at the screen of the computer and she said, oh, I can see that the previous doctor said that this is a viral cough. And I didn't really think anything of it at the time, but it feels like she'd already sort of made her mind up. Anyway, she examined William, and I can remember her words as clear as day. And she said, oh, I can hear some crackles on his chest. So I said, do you think that he should have some antibiotics now? You know, this cough has been going on for 5 to 6 weeks now. He's, you know, was sick this morning because he coughed so much, and it's sort of keeping him up a bit at night. And she said, no, I don't think so. She said, little chests are very difficult to listen to, and the sounds sort of reverberate off of that upper respiratory tract. And so I was like, oh, okay. And she recognised that we have a really strong family history of asthma. I spent half of my childhood in hospital with brittle asthma, and we've got terrible lungs. And so she prescribed him a Ventolin inhaler and one of those little aero chambers. And she said to give him that before he eats, before he goes to bed, and before he sort of goes inside to outside where the temperature would upset his cough. So I thought, right, okay, well, that's, you know, so that's something. So I took him home and I let him play with it, and he took it really well, and well as a 1-year-old would take it. He tolerated it. He was a really placid baby, and my other son, Arthur's quite feral or spirited, whichever way you want to look at it. And he doesn't like to be touched. He doesn't like the stethoscope on his chest. He doesn't like his hair being cut. Whereas William was really placid, and that's sort of quite relevant later on. So we'd given him this inhaler, and it didn't really seem to make much difference. And he sort of continued to cough and continued to cough. And I picked him up from nursery on a Thursday evening, and I brought him home, and he had spaghetti bolognese, and he was covered in it. And so I took him upstairs for a bath, and then we built a den. And that was probably the last time that I ever really heard him belly laugh. That night, I woke up to him crying, and I went in, and he had bright red cheeks, and his little fists were going in his mouth, and he was dribbling. He was cutting 5 teeth. So I gave him some Calpol and I cuddled him, and he went back to sleep. I woke up in the morning, and he got up, and he didn't really want any breakfast. He sort of pushed his toast around. I couldn't tempt him with some strawberries or blueberries. I just couldn't tempt him with anything, really. He didn't seem very respondent to it. So I said to Paul, I might keep him off nursery today, because it being a Friday. And as soon as I said the word nursery, his ears sort of pricked up and he crawled towards the front door. And that was his little thing. I would say, it's time for nursery, William. And he had crawled towards the front door, ready to put his little shoes on. So I said, well, maybe I'll take him in. He'll probably perk up a little bit around his little friends. And so I took him in and I said that he'd not had his breakfast, so he'd probably be ravenous for his morning snack. And so I said that I'd given him Calpol about 1-2 o'clock in the morning, so they could give him some more if he was in discomfort with his teeth. I get a phone call about 11 o'clock to say that he'd refused his morning snack, which I thought was quite unusual, and that he started to feel quite warm. He had a temperature of 38, so they'd given him some Calpol and he was really tired. They said he was really tired, so we've put him down for a nap. And I said, right, as soon as he wakes up, give me a ring and I'll come and get him. So I get a phone call about 11:30 to say that he's not woken up, but they've taken his temperature again and it's now 38.4. So I said, right, I'm going to come in and get him. And this was a Friday. And so when I was in the car, on the car phone, I called our doctor and they didn't have any appointments. I asked if I could have an appointment with the duty doctor or that, a locum. And they said, we don't have any appointments whatsoever. I said, but he really needs to be seen. He's not right. He's had this cough for weeks. He was up last night with his teeth and he's got this temperature that's not going down. He's just not himself. I said, can I take him up to A&E? Now, the geography of Cornwall is we've got one acute hospital. We've got one A&E. And I didn't know at the time, but they were on black alert, Opal 4, unless you had arterial spray, you were not coming in the front door type thing. And she could, the receptionist could hear that I was, obviously concerned. So she said, look, come in at the very end of the day and we'll just put you on the end. So we took him home. And you can see from this photo, he's really grumpy, really grisly. His lips are bright pink. He was hot. He was bothered. He had just his vest on, and that was really too much, to be honest. And by the time we took him back to the doctors and we got in, it was about 5:40, and it was the same doctor we'd seen the first couple of times. By the time we got in, his temperature was 40.1, and he was combative, I suppose is a word. He was fighting against being held by the doctor. He didn't, it was very unlike William. He was pushing him away. He was grumbling. He was sort of crying. He just didn't want to be touched. And I was like, something's just not right. Something's not right. He's not right. And so eventually we calmed him down and he stopped crying. And the doctor listened to his chest and he said his chest is entirely clear. He looked in his ears and they're clear. He looked in his throat, clear. He recognised he had this really high temperature and he said the likelihood is this is just a viral infection coupled with his teething and, Calpol fluids and plenty of rest type things. So I thought, right, okay. And so as I'm walking out of the door, I can remember poking my head back in and saying, when do we take him in? As in sort of, we're going into the weekend. And he said, don't worry, it's nothing grisly. So we didn't get any advice on what worse looked like or what to look out for. So we took him home, got supplies of Nurofen and Calpol and things, and he went to bed and he was exhausted. And Paul and I were faffing. We were due to get married on the Monday and then go to Spain on the Tuesday. So I was in full faff mode and I don't know what Paul was doing, probably doing the car or something. And that night I had to go in and give him some Calpol a couple of times, but I noticed that his temperature was not getting as high now. So he wasn't, I didn't think he probably needed it by the next day. And as the Saturday wore on, I couldn't tempt him with any food. I couldn't, every time I gave him little bits of water or milk, he'd bring it up and it was sort of green. And I said to Paul, although the one thing the doctor said is get on top of his temperature, and his temperature was now lower, I said, he seems so much worse. He seems, he's just not himself at all. And this is our sofa, and this is a quilt on the sofa because we had a leather sofa, but he just wouldn't tolerate any clothes on him. It was almost as if, when you touch and it was like hurting him. He just sort of cried. He didn't want it on him. And he was whining and he was sort of making a funny noise. So I said to Paul, I'm going to ring 111. So I called 111 and they asked us to take his temperature 3 times during the phone call, and it was 35.4, and they said, that's good, you've got his temperature down. So I thought, well, that's good. And I said, he's not eating or drinking, and he's not been to the toilet since Thursday, and he hasn't had to change his nappies. And they said, well, if he's not eating and drinking, he's not going to be going to the toilet. So I thought, right, okay. And I said that he sort of felt really like cold. And they said, well, if he doesn't want to tolerate clothes on him, he's going to be quite chilly. So they said, try and sort of keep a blanket on him. And they asked me during this phone call if he was in pain. And I said, well, he can't really tell me because he's non-verbal. But I said he was sort of bringing his knees up and he was making this really whining, funny cry. I said, he's really pale. And they said, well, if he's got a viral infection, he's probably really under the weather, you know. And they said that this was a non-urgent 6-hour callback. And so I hung up and I sort of carried on looking after him, I suppose. And this is the last photo that I've got of me and William alive. And you can see now that his lips are completely devoid of colour. He was just tired, really tired. So that evening, it was only a couple of hours after this photo, I put him up to bed and I put him in his cot and I put his little arm around his reindeer and I said, good night, sweetheart, I love you. And they were the last words he ever heard me speak. And and anyone that's got children know that when you put a child down to sleep, you stealth out of the room so as not to wake them up. But I stood at the end of his cot and I thought, something's not right, you're not right. So I went downstairs and I called 111 back and I asked to be, I'd wait and I'd asked to be put through to the local sort of doctor, the out of hours, you know, which took about 40 minutes. And one of the first things that he said to me was that he had a waiting room full of people and it was so busy. So I thought, crikey, I better get on with this. And I'd said that he, you know, he'd had this cold and this cough for weeks now, and that he had been sick, and yesterday he'd been sick quite a bit and it was green and his temperature was over 40 yesterday and now it was sort of 35.4. And he reiterated what 111 had said, that I'd got on top of the temperature, so likely he's starting to kick the infection and that it's just viral. And they played this phone call out at the inquest and they said that and I said it in this tone and these words, and I don't think I thought about it at the time, but I said, in your professional opinion, what do you think I should do? Because listening to that phone call back, he was being very reactive rather than proactive. I was leading all of the questions and saying, but what about this? And but what about that? And he said, if he's already in bed, that's the best place for him. Keep up with Calpol if he needs it, fluids and plenty of rest. He'll be right as ninepence in the morning. And so I said, well, what happens if he gets worse? And he said, well, you ring 111 again, you have to come through that way. So I thought, right, okay. So I checked on him when I went to bed about 11 and he was sort of snoring, and I went in and checked on him about 1:30, I suppose, and he was sort of sleeping soundly, and I heard some rustling at about 5:30, and we had one of those baby spying monitors, and I could see that he was sort of taking some drink from his sippy cup, and I thought, that's good, he's going to be really thirsty, he's going to want some porridge in the morning. Anyway, I woke up just after 8, I think it was, and I didn't have my glasses on, and we had blackout blinds in his room, and I nipped to the loo and I opened his door and I could smell that he'd been to the toilet, which I thought was really odd because he was, you know, he was over 1 now. He just didn't go to the toilet, you know, in the night. And I was talking to him and I was saying, William, William, and he didn't make any noises. And I went over to the bar of the cot and I stroked his cheek and it was warm, but he didn't move. And I knelt down and I put my arm through the bar of the cot and I stroked his arm and it was cold. but he didn't stir. And I stroked his side and he was stiff. And I immediately shot up and opened the blinds, and I could see that he was dead. And his eyes had fallen open and he was staring straight through me. And I just started screaming. I started screaming to Paul, he's not breathing, he's dead. And I ran into the bedroom to get the phone, and Paul ran past me and started screaming. I ran down and opened the door for the paramedics, and Paul had lifted him out of the cot and put him on the floor, and he stayed in the position he died in because he was in rigor. And I can remember just focusing on the digital display on the phone whilst the lady was going through and 1 and 2 and 3 and 4 and 1, and I couldn't open his mouth to give him rescue breaths because he was in rigor. And the paramedics come thundering up the stairs after 3 minutes and 44 seconds. We actually lived just around the corner from the ambulance station, and this was a Sunday morning. And they started working on him. But after 7 minutes, they turned to me and said, I'm sorry, my love, but he's gone. And I just started screaming, and they held me until I stopped. And then I laid on his bedroom floor with my cheek on his, and I begged him to wake up, knowing that he never would. We were conveyed to hospital, where they took this next photo. This is the last photo that I have of me and my son. This is the reality of not thinking sepsis. This is the reality of many mums and dads. This is the reality of thousands of people every year who lose parents, who lose friends and family. I got to hold him 15 more times after this photo was taken. I'll move that on. I could probably stop sharing now, so there are no more photos. I'm sorry. And we had him christened, and then he was taken to, they said, we've got to take him away now. And I said, where are you taking him? And they said, the morgue. And I carried him along the corridor to the man that came out of these big grey metal doors. And I said, you're just going to have to take him. I can't give him to you. And he took him. And that was the last time that he was ever really mine. And I was stood there in my pyjamas. I had no underwear on. I had no shoes on. And we had to leave the hospital and pay for my mother-in-law's car park. And I didn't know what the hell had happened. And we obviously didn't get married. We obviously didn't go to Spain. And I got a phone call on Christmas Eve, and it was the coroner, and she said she had William's body back for Christmas. So, and then she said, did William have a cough? And I sort of laughed, like a nervous laugh. I said, yeah, he'd had a cough for weeks. How do you know, you know? And she said, well, he had pneumonia. And I said, what do you mean he had pneumonia? I said, I took him to the doctors like 4 or 5 times about this cough and losing weight. And she said, well, he had a collapsed lung, and he had a pleural effusion in his left lung cavity, and there was over 200 mils of viscous fluid. And then she said he died of sepsis. And I thought, bloody hell, what's that? I said, that must be so rare. Like, I've never heard of that. And I had checked all over him for that meningococcal rash. I'd even checked in between his bum cheeks and in between his toes in case I'd missed that tiny little rash, you know, but there wasn't one. And so we had to go through an inquest, and I spoke to the medical examiner that performed William's post-mortem, and he said the collapsed lung would have been there on the Friday, and the viscosity of the fluid in his lung was quite old, so it'd been building over the last week. And he said ultimately William had a bacterial chest infection in those weeks leading up to his death, and obviously developed pneumonia. It's likely that if he had been given antibiotics at that earlier stage, that he'd have got over the chest infection, as most people do. But you know, even if he didn't and he went on to develop pneumonia, as some people do, he'd have been on the radar, a different course of antibiotics, a hospital admission, chest x-ray, whatever it might be. The difference is he'd have had a chance. He'd have had a chance. And lots of people say to me, well, at least he died at home, not in hospital. But I feel like covered in wires and tubes and in, say, Ron's intensive care, he'd have had a chance to survive. And it was found that there were 16 failings in his care and 4 missed opportunities to save his life. And I won't go on because I know that we're sort of at the end of the meeting now. There's been lots and lots of change since William died, that the Sepsis Trust and others have done. But William would be 10 now, and he never got to meet his little brother. I never got to hear him say, I love you. And so all I ask as a mum, as someone that's lost someone to sepsis, is please, you have the ability to think sepsis always. And even if you think it, and this person in front of you is saying, could it be sepsis? And you don't think it is for whatever reason, give them the reasons why it's not sepsis. Explain to them what sepsis is. Give them safety netting advice when they go home to say, this is what worse looks like, and this is what you could do if this happens. But always think sepsis, because that one thought could be the difference between someone's life and someone's death. And you just simply don't get a second chance with sepsis, and knowledge really is power. So I will end there because I would want to leave a minute for questions. I don't want to run over, so I'm sorry. I'll blame Ron, it's fine, he ran over.
All I can say is just echoing what people are saying in the chat, Melissa. Thank you so much for sharing your story, and there's never any need to apologise. It's incredibly moving, and I mean, there's not too much I can say other than the first thing that Ron said at the beginning was that, you know, in the UK this affects over 200,000 people a year, with almost 50,000 people a year losing their lives with sepsis-related illness. It's terrible, but thank you so much for sharing your personal story. I know that Ron has answered some of the questions in the chat. We do have a minute left if anyone wanted to say, but I would ask Ron, is there a way that people can get in touch with the UK Sepsis Trust if they'd like to?
Yeah, absolutely. So, yeah, we're a bit like the BBC, really. If you know one email address, you won't know them all. So I'm Ron.Daniels.
Oh,
I don't think my signal's good enough at the moment.
We can hear you,
I think Ron is ron.daniels@sepsistrust.org. However, I'm only Melissa at sepsistrust.org. But as I say, you know, as an organisation, we have a clinical offering, we have tools, we have e-learning, and we have a support system in place that helps organisations with their clinical outreach when patients have been discharged or even before they've been discharged. And we do lots of other things, like we have wonderful volunteers and fundraising. So if anyone wants to get involved, please do, especially around World Sepsis Day. We always need people to amplify our message. And I just want to say thank you for the lovely comments in the chat there. I don't get to talk about William in the way that other people talk, I suppose, about their children. So by sharing his death, I get to share his life, and so that's what I'll continue to do. So thank you.
Thank you so much, Melissa, and yeah, please thank you for sharing William's story. I'd just like to end by saying thank you so much to the UK Sepsis Trust for joining the SHBN and Patient Safety Learning for this call today. If everyone else on the call is like me, it's been incredibly moving. So thank you, Melissa. Please do reach out to the Sepsis Trust, and please do join us for our next one. So thank you, Ron. Thank you, Melissa, and enjoy the rest of your day, everyone. Thank you.
Thank you for having us.
Thank you.
Thank you. Bye.
Bye.